I need to call the Human Services meeting to order, please. Calling the Human Services meeting to order. Do we have any courtesy of the floor? Kevin.
You're supposed to be in the seat.
Seeing none, we'll move on to the report from the Director of Human Services. It was 5 minutes. It's 10 after.
We should have some kind of buzzer that lets you know.
I'm going to bring a dinner bill next month, okay? A little ding, ding, ding. I will get Steve's phone.
Hello, all. Thank you for letting me go first. I know we could spend weeks talking about Graysdale. So since we didn't get to meet in December for Human Services and January was a rush, I have been carrying over quite an agenda. So I appreciate being able to share that with you. I probably have updates for almost every one of our divisions. I'll start with children and youth. I think I told you last month that we have very few open positions left in children and youth, and I did confirm that if not all, then maybe all but one or two that are vacant are only vacant because of folks who were promoted, and we have that 90-day right of return period where we cannot replace them. And I am told it is the highest staffing levels they have had in a very long time. So that is really exciting for us. Now, a lot of those folks are new, and it's certainly 6 to 12 months. First 6 to 12 months is a huge learning curve. There's a ton of training, but we have folks there now and are excited to be able to make some additional forward movement on some of the initiatives that they're doing. So thank you for approving those positions. They are actually almost full. Kevin Dolan has been here in the past to talk about the Family Engagement Initiative. I know you guys have heard about that. And I just wanted to give you a quick update. The folks from the AOPC were at our building a few weeks ago to meet with both children and youth staff and supervisors, as well as the judicial staff who are involved, and had nothing but exceptionally high praise for the work that Northampton County is doing. And we were told, perhaps off the record, I'm sure, but I'm sharing it anyway. We could be off the record for their purposes. That just repeating it. That that Northampton County is 20 steps ahead of everybody else. Now that number I'm making up, but that we are far exceeding the work of our neighbors. So and yet that said, we have a lot of work left to do with that initiative. But I gave you the stats last month, so I won't repeat those. But I didn't think I had time to actually give the specific comments, and that was great. The Family First Prevention Services Act. I don't think I've talked about that yet. It's new legislation, so I just wanted to kind of give folks a heads up. This is potentially going to really change the way that we're able to work in children and youth. Essentially, and this is the totally watered down gist here, is that the federal government would like to start allowing funding to be used for prevention services to prevent foster care placements in the first place, which is fabulous, and that's what folks have been wanting for a very long time. The catch, because there's always a catch, is that they're not going to fund residential treatment facilities, congregate care, also known as congregate care, past a certain number of days, which is a very short time period, and if you're not on this California approved registry, there's a whole lot of criteria that the residential treatment facilities have to meet. Frankly, I agree with all of them. They have to be using evidence-based treatment practices. The problem is, I think in children and youth, we, at last count, so it's not an exact give or take a few, we had about 27 kids in congregate care. Some of those children absolutely have to be in residential treatment facilities. because it's the only safe place for them.
Right.
Others are languishing because we don't have the appropriate community resources for them. They've completed their work at a facility, but there aren't necessarily many foster families who, despite how well a child may have done in treatment, who want to take a child who has had sexual offenses or fire-setting behaviors. So I only share this because, you know, moving forward, Pennsylvania has until the end of this year to decide whether or not to jump on board with this initiative, or if they're going to delay the process. So we will. So anyway, what they're really trying to work on, although not enough in my mind, is, and I think our children and youth folks agree, is if we're not going to fund residential treatment facilities, what are we going to build in the community? What supports are we going to be able to offer to allow these kids to be out of residential treatment facilities? So more to come on that, but it's exciting to be able to use money for prevention, but we have to figure out the back end of it as well. Any questions about that?
Yes.
But
If you want to continue, I have
Sure.
questions regarding children and youth.
I only have one more item for children and youth. Did somebody have a question about?
No, I
Did you have a
was
question?
just saying
Oh,
Bob
okay.
had a question.
The only other thing for children and youth, and then I could take questions. There is a Governor's Institute on Plans of Safe Care. I had alluded to a program that we were working on, contracting with a community agency for mothers, pregnant moms who are have drug addictions, in order to try to plan for the care of the baby following birth, prior to the baby being born, so we can avoid, again, children and youth placement. So the Pennsylvania has assembled a plan with plans of safe care, and it's multidisciplinary. So we have children and youth folks, drug and alcohol, early intervention, community health folks, all gathering. Our group is going in March to Kalahari for a couple of days to learn about that initiative and learn how to spell that out. So we're really excited about that. And in fact, Jess Whiteneck, who was here from early intervention, is actually going to be the spearheader of that, which is nice. That children and youth will be involved, but they don't have to be the leader. So we're really excited about that. Questions, Mr. Werner? A question?
In September of last year, Kevin Dolan reached out to us for strong, heartfelt requests. They had 3 wish list items.
Okay.
The first one was consideration for civil service programs to be revamped for the ease of facilitation. Have we done anything, yes or no?
I would love to say yes. It's a conversation I've had with Liz Kelly. It is a very complicated process that civil service requires us to engage in to do away with. Well, we have career service, so it's a sort of a start, but no, it's been discussed, but no, it has not been changed.
Okay, second question.
Mm-hmm.
I'll try to make this simple.
That's okay.
Reducing forms paperwork required by risk assessment programs. Have we done anything about that yet?
We don't have a choice. We have no say in that matter. That's a state issue, but I will tell you with the Auditor General's report that had come out, that was one of the recommendations, and so some of the, I think it's OCYF, Office of Children, Youth, and Families, has been convening to try to figure out how to combine some of the things that you're talking about, but we don't really have a say in that.
And last but not least, if I may, sorry, third question I have, there was a question on flexibility on mandatory 20-hour training for kinship home programs. Has anything done with that? Yes, ma'am.
That's new to me. That's not even accurate. They're not required to have 20 hours. So, unless he's talking about for kinship foster parents to be approved initially, they are required to have 6 hours of training. That is a state mandate, which we can do nothing about. The 20 hours, I suspect, is for then ongoing every year thereafter, which again is a state mandate, and we have no control over. So.
All right. Those are my questions. Thank
You're welcome. I
Chairman,
wish
can
his wish list was something I could help with.
Let me ask, how much more do you have to cover? Because we're just on children and youth, and people are having questions about that.
No, it's fine. I don't.
Okay, go ahead.
Look, I have a long list,
No,
but
it's Ron had
it's
questions,
quick.
so-
My list is quick. So
Okay,
whatever
go ahead.
questions, I have a long list. but
Hopefully,
it's
this is a quick question. On the issue of civil service, about change, and you talked to Liz Kelly, I mean, isn't that sort of like the second answer you gave? That's really at the state level. I mean, there's not much we can do about civil service. We've been talking about changing that for 30 years.
Well, the county has the option to opt out of civil service, but it's not just like, hey, let's opt out of civil
There are
service.
the
It's-
ramifications that come with that.
Well, there are, and you have to have an entire system built essentially to replace civil service. I will say that the Civil Service Office is now under the Office of Administration at the state and has a new commissioner who I had worked with. She was the aging commissioner or secretary for the state, Teresa Osborne, and we are cautiously optimistic that at least there will be some positive changes made. And I can tell you there have been positive changes made since they switched the system over in April. It was awful for the first 6 months. It is definitely, we figured it out, and so it is better. It still causes us delays and problems from time to time, but so yes, we do have that option, but it's not easy.
I just was, that was brought up. I'd be very cautious with that option because I know there's some folks who don't understand completely your end that you need to worry about with the finances of the jobs. That could present a problem. I mean, it gives you control, but
No, and
then you're
listen,
in.
now we're at a place where we are almost fully staffed and are as staffed as we can probably be. So we've figured it out enough to work around it.
Thanks.
So,
Yeah, thank you. I'm done.
okay. The VA office. So it turns out, one of the questions that I think Ms. Fargo-Hefner had asked was about sort of electronic record keeping, some sort of system. It turns out the VA office has one. And the clerical person has always been doing it, and now Mr. Ramirez is as well. So we have the ability to run reports on how many calls and how many walk-ins we get each month, and we've categorized them into some different areas. So just as some examples, December, we had 101 contacts, so those walk-ins and phone calls. Majority of those visits were for help with compensation benefits, which is largely what he does, what Mr. Ramirez does. This time of year, real estate tax exemption. But the compensation is always the leading issue that brings folks to our VA office. In January, there were 76 contacts, and 30 of those, which is far more than any other reason, were for, again, help with compensation. So I believe we have the ability to run it by male, female, and some different categories. I didn't run that level of a report, but I did want folks to know that we actually have that data now. Yep.
May I ask a question on that then? At the end of the year, we get a CAFR, a comprehensive financial report, and there are statistics included. And I think from my recollection is that we don't have statistics from VA in there. Would it be possible to include that in the CAFR at the year end?
I don't see why not. I'm not familiar with the report you're talking about, but now that I know we have stats and I'm running monthly reports, I'm sure would be happy to provide you with that.
Yeah, I think it should be available and possible. That way we could track the trends and how many people we're serving. I think that was one of the main thrusts of Ms. Fargo-Hefner's line of questioning with Mr. Ramirez, is that we didn't have any data, and I think we could, if we could include this in the year-end financial report, that would be great.
Absolutely,
Thank you.
and you're more than welcome. One of the things I've talked to Mr. Ramirez about is if we don't have data and we don't know, I mean, I get it, most people are coming there for compensation. He knows that just from experience, but data is data, and that's what talks. So if we know that people are also, a large number of folks are coming in for another issue, maybe there's additional services we can provide or grant funding we can seek, and we couldn't do that without the data. So, so I'm happy about that. The claims data is the only other thing for the VA, and I've given you some numbers before. So July to November of 2018, for example, there were a total of over $500,000 in compensation benefits awarded to the folks that Mr. Ramirez and Ms. Young help serve. So I like to share those because that's some good news. Any other VA questions? Okie dokie. Drug and alcohol. We received 2 grants fairly recently. Actually, one was back in September already. That was a $55,000 grant to use for college campus prevention programming. Last year, we did an event at Northampton Community College. Mr. McClure was there and spoke. This year, and that the Center for Humanistic Change put that on for us. This year, they're going to be adding an event at Lehigh and Lafayette. I believe both. I'm not. I forget now if I'm 100% correct. And that grant funding is used for training staff on evidence-based programming, training curriculum, and prevention services. So that was I was going to say small grant. That's the world that I live in now, but it's obviously not a small grant. But the other grant that we received, last month, but time flies, I think it was January, was $439,000 for additional case management and CRS services, which is Certified Recovery Specialist. And so this will allow one of our providers to hire 4 additional full-time staff. And I believe the grant is guaranteed for 2 years, and then we'll see from there. The really exciting thing was 8 of the surrounding counties applied, and Beth Miller, our administrator, was the only one to actually receive any money. So she's did an excellent job on the grant.
Is there an agency that's targeted to receive that, or is it getting dispersed across different agencies?
When we were considering applying for the grant, we invited all of our outpatient providers to come to the table. And I think there's 4 or 5 of them in Northampton County. 2 of them then expressed interest in moving forward. Recovery Revolution and Lehigh Valley Drug and Alcohol Intake. Ultimately, so that grant money was going to be split. But there is WITS data. That acronym I don't know, but it's state data that we are required to input for any client who is receiving services related to this grant funding. And Recovery Revolution does not feel comfortable doing that at this point because they feel there's some confidentiality issues despite assurances from the state. So there seems to be some confusion about the difference between case management services and treatment services. Treatment services, there's a different level of confidentiality, but so we receive the state money and send it to a provider, and in order for us to be in compliance, the provider has to do the things that are required as part of the grant. And so because this one provider was not willing or didn't feel able to, Recovery Revolution, they were unable to receive the funding. So,
Okay.
Can I just ask a question?
Sure.
Just so I understand,
Mhm.
so when you go for the grant,
Mhm.
the companies that might be doing the services, they jump on board with you prior to receiving the grant. Do they also give you do they put some input?
It depends on the grant. Yes, the answer is yes,
Okay,
ultimately.
That's all. I was just trying to
Yep.
see how that, and then they did that, and then at the end of the day, then.
Yep. The ones that were interested, I think the big thing that they provide us is what they would do with the service and what they think their budget would be. I think those are the biggest pieces. It does depend on the grant for sure, but this one absolutely there was involvement. And then we just invite all the players to the table. There's no cherry picking. Everybody gets the same opportunities.
And will the CRS folks be split at the 4 recovery centers, or?
I can find
don't-
that out. I don't know that offhand how they're being utilized. I think I know, but I'd rather not be
Okay.
wrong. I can get back to you.
Did you have a question? I'm sorry. No motion.
Okay. Any other questions on that? Make sure I'm not getting lost. The PAIR program. This was the B-PAIR program, Bethlehem Bangor Police Assisting in Recovery. It's now just the PAIR program because we have additional police departments on board with this besides Bethlehem and Bangor. This was modeled after the Angel program developed by the Gloucester Police Department, and this started in 2018, and I thought it was before that, but it must have been right around the time that we started. So what happens with this program is anybody with a substance abuse issue can go to any police department, ask for help, and receive a drug and alcohol intake, and right on site at the police department, and then subsequently get connected to a treatment facility. So what happens is if somebody does show up at the police department asking for help, they contact our on-call assessor, who goes to the police department, and if there are no beds immediately available, if that's what the person requires, if they require inpatient, then we connect them immediately with the CRS services to provide some, as close as possible, support until a bed becomes available. And that is available 7 days a week from 9 a.m. to midnight. And we would consider funding that overnight, except the need has not yet presented itself. So the other folks that have jumped on board now, we're currently in the process of adding are the Bethlehem Police Department, Colonial Regional Police Department, I already said Bethlehem, and Easton. And I lost my note, but I think I was just told that the Bethlehem Township Police Department, which we were happy about, and one other police department have expressed interest. So this is a primarily grant-funded program that is actually run by the Bethlehem Health Department, and we supplement it with a small amount of money. And the other piece related to that, just because obviously this is a hot topic, Bethlehem Police Department also conducts home visits for someone who ends up in the ER for an overdose. So following that, a police officer and a certified recovery specialist make a home visit to try to engage that person and get them into treatment if they are willing. So hopefully we can expand that piece. Any questions? Okay, I really am moving along pretty well. For the aging division, I don't even know, we now have an official deputy director. I'm not sure if I don't think I said that last month. Lori Stanton-Laney is now our deputy director, although Lori Greco has been out for about 6 weeks, and so we're anxiously awaiting her arrival back to actually be kind of somewhat fully staffed. They have, I mean, you guys know how I feel about that division and the work those folks have done, but they have spent the first year pretty much primarily focused, Lori, on protective services, because that's the most critical and had the most work to be done. But what we've uncovered is that there are other things that absolutely need some revamping, and we're working on those. That's more related to our community-based services for our residents, and we're down 2 caseworkers and a supervisor, but our Spanish-speaking caseworker, which took a while to replace the person who retired in the fall, starts Monday. We're very excited, and I think the soup and the other caseworker are still posted with civil service. So that just is now that we've, for the most part, have protective services in a good place, we're able to really start devoting some time on the other divisions within aging to clean up, so to speak. So right now we have our emergency fuel assistance program for our folks over 60. We had allotted an initial $20,000, went through that, and just reauthorized an additional $15,000. So folks apply for LIHEAP first, but then if they are out of fuel or have heating bills and need help with, we work with the Project of Easton to have them make that connection and help with those bills. I think that goes through the end of March. So, and the Outstanding Senior Award Ceremony, which some of you have attended in the past, is on April 25th at 1 o'clock at the Wesleyan Methodist Church on Center Street in Bethlehem again. And everyone, this is your informal invitation. I do think there'll be a formal invitation that I can send to Ms. Zembo then at some point once I have that in my possession. Any questions about aging?
Question. Are we still performing ombudsman service for residents of Graysdale, the aging department?
We are. The person, there is a little bit of restructuring, and there's a consideration being given to use North Penn Legal Services to help us with that. But I need Lori to get back here, and we need to be able to kind of put that together and figure it out. But ultimately, that might be more efficient for North Penn to do it, and for us to use that staff person to meet some of the other needs within the aging division. So right now, the position is technically vacant because the person in that position went down to work in Iris, which was great for us still because, first of all, she's still there, but she's doing aging work for the Iris division. So we're just sort of, we're utilizing our volunteers, same as always in the meantime, for that. Other questions? Okay. I'm only have a few more things. The state they partnered with the Sandy Hook Foundation and implemented the Safe to Say Something program. Some of you may have heard about this if your kids are in school, middle school, high school, where essentially, whether it's through texting, phone calls, 24/7, students, teachers alike can utilize this number to call if they think that there's a safety concern at their school, or if they think that they're afraid that their peer is depressed or suicidal. So any sort of safety concern that a student or teacher might have at school, they can call Safe to Say Something. It's an anonymous reporting, and it's funded, or it started through the not funded, but it's the Attorney General's office. This is where it came from. Ultimately, it's funded by the Sandy Hook Foundation. And PA is the first state to make it an entire statewide initiative. So it started, I want to say, January 14th, and the first week alone they had over 400 phone calls. So we're anxious to see how that kind of trickles down to us at the county and to the Irish division. Depending upon the call and the concern, it gets routed either directly to the school or to the local law enforcement. So we haven't heard anything directly yet, but that was new. Any questions on that? Okay. The other big thing then that I wanted to tell you guys about is the Lehigh Valley Trauma Awareness Collaborative. This apparently started a couple years ago. And initially, there's a lot of Lehigh County folks involved, and the United Way is at the moment the backbone of this group. When I found out about it, in fact, I found out about it after Deb Nunez passed away because it was on her calendar. I stepped in and started going, and am really excited about this for the Lehigh Valley and Northampton County, obviously. But the goal, again, this was our initiative in the Lehigh Valley, but the Attorney General's office, again, is looking to have an initiative for PA to be a statewide trauma-informed, so trauma-informed statewide. And some of the Assistant Attorney General's reasons for this are to eliminate the school-to-prison pipeline, reduce substance abuse and opioid epidemic, reduce family and community violence, and reduce mass incarceration that traumatizes the children left behind. I don't know if folks saw the article a couple months ago now about Brockwell Middle School, but a couple years ago they revamped sort of their entire way that they do schooling and became trauma-informed and trauma-aware, and the results were staggering. I don't have that article with me, but it was not an easy process, but essentially the gist is we all have, most of us have some form of at least one trauma in our past, and that impacts us and impacts our brain development, especially children. And instead of looking at the behaviors, of children, understanding those behaviors and why they're occurring. And that's the, again, just super watered down version of what they're doing. But at Brockle, for example, their out-of-school suspension rates dropped dramatically. The grades improved. It just like everything just kept ticking off. And so I'm really excited to be a part of this initiative, and we're working on we've added some, probably about at least a half a dozen Northampton County folks on this collaborative. So more to come on that. We're working on grants and such.
Is it worth bringing them in for a presentation?
At some point, maybe. We can talk about
I'd
that.
like to hear more about that.
Yeah, it's very exciting. I do, in fact, that's the one thing what's the one handout I brought, which I can share with you guys. But just the final point on that, I'll pass those out then. So the ACEs, the adverse childhood experiences, a lot of mental health agencies and places use that to determine level of trauma experience. So if you have 1 adverse childhood experience, 2, 3, 4, parental divorce, separation, abuse, neglect, like all of our kids and children and youth have probably 2 at least, but certainly at least 1 plus. So Tennessee actually did a study on the economic costs of ACEs, adverse childhood experiences, and they focused on medical costs and worker absenteeism from health issues attributed to adverse childhood experiences. And in 2017, it was estimated that ACEs among Tennessee adults led to an estimated $5.2 billion in direct medical costs and lost productivity from employees missing work, which $5.2 billion is 1/7 of their state's annual budget. So this is just, this is where sort of child welfare and mental health is the direction it's going, and that just was, to be able to quantify things, just sort of puts a different spin on it. I only have 2 more short items. Any questions on that? Okay. 2 things for me for Graysdale. I told you guys a little while back about the mental health, what do we call it? Mental Health Aging Program, MHAP, that we partnered with Haven House to work in Graysdale. It's a team of master's level behavior therapist or behavior specialist, a bachelor's level counselor, and certified older adult peer specialist. So they started in January, and they have 20, they already have 20 residents that they're working with, which is amazing because our goal for them was, I think, only to get to 20 by the end of calendar year 1. And in month 1, they're at 20, and they're adding 3 new residents a week. So Haven House and Graysdale had a meeting and to make, just how's everything going, find out the progress. And I don't think, I would sort of be a competition to see which party was more pleased with the other party. Haven House is thrilled to be at Graysdale, and Graysdale is absolutely thrilled to have them. And I suspect that over time we will be adding some additional services that they can provide in terms of med management in instances where our current provider is not able to meet our needs. So I just wanted to give a shout out to all those folks. I think, and the big piece of that related to training, which I know Jen will talk about, is Haven House's staff's ability to work with our nursing staff and provide modeling and mentoring in terms of how to better interact with folks with mental illness and essentially how to de-escalate, more challenging and crisis situations.
So when you say that 20 residents are part of the caseload, then that's identifying currently existing residents.
Correct.
Not necessarily people as they're coming in the door.
No. So generally speaking, it's existing residents. That some of them might be newer. I mean, I'd have to get that data for you. But essentially, the social services folks are the ones who make the referrals to Haven House, which is, of course, done in partnership with the nursing staff and the folks who are on the floors with the residents every day. So, so that's their plan, is to add 3 a week. I'm not entirely sure what their max will be yet, but but we'll see. But the best part about it not being, at the moment, it's not funded by insurance. It's funded by Graysdale and county mental health dollars. But it gives us the freedom to run it how we like. And if somebody needs 10 minutes of counseling today, but an hour tomorrow, we can do that. The ultimate goal is to have this be a Magellan-funded program so we can expand it. But we need at least a year or two under our belts to be able to submit that and try to get approval for it. So that's down the road, hopefully. I have one more thing. Any other questions?
I'm going to wait. I don't want to.
Thanks.
I only have one more. Our Director of Nursing, Taurus Feldman, I am very excited to let you all know that she is now a certified nursing director in long-term care. When Dawn was hired, I was one of the first things she talked about. What do I need to do to get the certification, which is not required? And within 6 months had finished her training coursework and is now certified. So we are certainly very proud of that, and I wanted to let you all know that. Any questions before Graysdale?
Until after Graysdale.
The awareness thing for the
Trauma?
children, to call the phone.
Oh, the Safe to Say Something?
Yeah, do they have posters or?
So
are they
each-
coming out with them?
They're supposed to be in all the schools.
They're in schools now?
Yes, and I think they hit the public schools pretty quickly. My kids happen to go to Catholic school, and they were maybe 2 or 3 weeks later than everybody else, but even they had it. So I think for the most part, yeah. Yes, you're welcome.
Yeah, who doesn't always?
And then just in terms of Graysdale, Ms. Vargo and Hefner and I have talked about it, and Jen and I, we could spend hours and hours, obviously, every month talking about Graysdale and still not be finished. And so we appreciate the need for more time. I think one of the things we talked about was going through the regular monthly report that Jen has compiled in a more simplistic version that Ray, similar to Premier, used to do, but easier and shorter. And then obviously answering any questions and maybe tackling one particular area each month in more detail. Obviously, whatever council wants is we're happy to accommodate, but I suspect there'll be a lot of questions and a lot of topics for conversation over the coming months. So we're just trying to thoughtfully plan and prepare for that so you guys have enough time and get your questions answered. So
If we get that information, like Premier used to give us, if we can get that in an email like the week before,
and then you can look
it
at
over, digest it,
Okay.
and if we have any questions, that one on the go down, line on them.
some of the problem is we can absolutely do that. I don't know how much in advance because of when the data is finished and compiled for the previous month. But even if it's only a couple days before,
Yeah.
we can absolutely do that so you have time to look at it beforehand. But it's only, what, 2 pages? 2 or 3
Yeah.
pages. So we've definitely made it easier to digest.
Yeah.
So, but that's we'll go ahead and do that. Anything else? Yeah.
May I?
Yes.
First of all, congratulations, you made it for a year.
Yes.
No one said that, right? A year and a month? Okay.
Yes, sir.
And I told you,
You did?
yeah.
I love it here, by the way.
I warned you, actually.
I love it. I do.
Before we do anything, I did a review of a year with Premier and a year with what has happened over your controls, okay?
Mm-hmm.
And I have short questions, yes and no. I'm not going to make this lengthy, okay? Prior to removing Premier as the administrator of Graysdale, was there or is there a written management plan that the county management of Graysdale? You have one.
Me personally,
Yes.
I don't. I have to get that answer for you.
So you don't have one right
I mean,
now?
I don't have one in my possession. I'm
Is
not
there
sure.
one in existence that you know of?
I would have to defer to somebody else. I will get back to you.
All right. Second question real fast, okay? Prior to removing Premier at the end of 2018, was there any effort from the administration or you to memorialize or preserve data for future references, anything that would help for the future?
From Premier,
From
you
the
mean?
data, yes.
We have all. Yes, we have all of their. We've retained all of their data.
You've retained the data. Have you done anything with it?
Well, I think in terms of just understanding that the data is not very accurate, which we talked about last month, which was not known before.
You're saying the data wasn't accurate.
Some of the data we suspect was inaccurate. So are we doing anything with it? I mean, absolutely. First of all, we're trying to recognize what's accurate and what's not, and more importantly, maybe even is focusing on the areas that we know have been a problem, and falls, wounds, those kind of things.
Okay, that's fine.
Okay.
If I may continue, one more fast. When Premier took over the reins of Graysdale, there were operational assessments done. Do we have them, and did you do an operational assessment of what you were going to do?
I do not have that. I did not personally do an operational assessment.
No, but this group before you did, and they went through things. I'm just curious how did you go about taking over the reign? What did you target research?
Well,
Well, I can answer that because it was
Thank
my
you.
decision. Yeah, no, don't. It's okay.
I'm not trying to put you on the spot. I was just,
Well, no, that's your job, right? To put us on the spot, and so we are.
Sometimes,
and we'll answer you. So, would you repeat the question? So
The question
I can
was,
answer it specifically.
there was an operational assessment that was done.
Operational assessment.
Yes.
Okay. No, I didn't do an operational assessment. I spent 2018 talking to all the relevant folks at Graysdale about what Premier offered us, and the only thing that we could determine that they did for us that we couldn't do in-house better was the cost assessment in accounting. Everything else, they either weren't doing anything or we could do it better in-house with the staff that we have.
Okay, and you
So
determined.
then I made the decision to move forward to stop paying them nearly $500,000 a year to not do anything and lead us to 11 deficiencies.
My question then is, how did you determine you were going to do a better job without a plan?
Well, how did I determine we were going to do a better job without a plan?
Yes.
By understanding that we were paying them $500,000 a year after watching the house be managed for a year, and understanding that they weren't doing anything that was making anyone's situation at Graysdale better. They had crushed the morale at Graysdale. We had seen falls and wounds skyrocket under their leadership, so we understood that we could do a better job based on our interviews of the folks for a year who worked there.
Okay.
So I mean, no, we didn't have a
You didn't have a plan or an
D.
operational
Millard.
assessment.
We didn't have a D. Millard Freeman operational assessment or anything like that.
I didn't, and I wasn't looking for that. I was just saying where was the plan of attack.
Right.
The other question,
Well,
part of that is that there's no question that, and I'm not going to throw Premier under the bus totally, because they did have a big part of turning some of these things around. They handled a power outage at Graysdale, and they were there personally. They did bed capacities, reductions of 37 beds, bringing $800,000. Okay, they had fringe benefit, target research on fringe benefit, and target research on team staff efficiencies. Those are the kind of things I'm asking about, because you have a new team coming in, and in order to have a new team coming in, let's have a playbook.
Right.
Okay, let's do something. So this is in no way trying to demean you in what you did. I'm merely stating that I'm still waiting to hear the programs that are going to be put in place that you guys have.
We talk with you every time we're here about the programs that we're putting in place. And we've been doing that throughout 2018, despite not having any support from Premier whatsoever. But you have the folks here from Graysdale who you can ask about what they're doing, and they can tell you again about all the things they're doing.
All right. Thank you.
And just to, I guess, to add to that, in terms of one of the things I touched on briefly last time was Dawn and her ability, her ability to work through position control. So when you talk about assessments, no formal assessments for me, but that has not been tackled in apparently years and years, and it's a beast. I mean, it's every position that's approved and budgeted at Graysdale, right? So it's just hundreds and hundreds
It's
and
like a
hundreds.
big audit. Yep.
So what Dawn has already done, and this actually would have been on our agenda probably for next month, simply because of time constraints for tonight. I wanted her to talk about position control, but the gist of it is, without going on too long, is that she has spent the last few months analyzing each floor, what the needs are, and how many staff we need. How many full-time staff, how many part-time staff, RNs, LPNs, aides to efficiently run the floors while maintaining our budget. And she has those numbers. And so for the past couple of months, we've been working to, there were apparently a lot of people at Graysdale who were part-time and working 70 hours in 2 weeks. And what we did was through the whole HR process, which I don't know all of those particulars, a lot of those people interviewed and opted into a true part-time job, 0.2, 0.3, whatever the FT is, so that we can more accurately assess what our needs are on each floor. And that is a work in progress. We were combining some per diem positions into part-time positions so that we can decrease our reliance on per diem folks. I suspect there'll always be a need for those folks, but the very heavy reliance on them was out of control.
Okay,
so,
can I?
Yeah.
I just want to throw one. I'm going to shut up after this
okay.
question. There was a time frame that each, I guess that they call it patient to or
Yes.
staff to patient time.
PPD.
Okay? It was at one time 4 hours per patient.
At Graysdale?
Yes. Do we know what that is now?
Yes.
Okay.
It is,
Are we still the same?
it is budgeted. No, it is budgeted to be 3.2.
Okay.
Now, prior to Dawn starting and the hiring, which, I mean, you all were here for the begging and pleading, and we finally had a team in place to actually do hiring. And it was in last year with Premier, I'm not saying this was Premiership, but when they were still here, the PPD was, the minimum is 2.7. And the PPD hovered 2.8, 2.9, 2.72. It hovered very close to that. We've now been consistently 3.2 for about the last month or two, and sometimes a little bit above that. So we're working to maintain that. Four is probably a little heavy.
4 would be at the top end, and that's for diabetes and heart problems, congestive heart failure, for things that would need that kind of care. I was just curious if you have those stats now that you're monitoring those.
They, and in fact, even when Premier was still here, I would get the daily PPD, like they would average it out per day, and I said, that's great, it doesn't tell me anything because I want to know what first shift is, second shift, because we all knew second shift was struggling. And so many months ago, Jen and Brian Dunlap went ahead and made the changes to be able to start acquiring that data.
Okay.
Better if you ask me specific questions.
Well,
sometimes I don't. No. We've done assessments, not that. That's okay.
I have no further questions.
Well, I guess I just want to ask, do you want to ask her questions, or do you want to bring the Graysdale folks
Well,
up
I
if it's
think
Graysdale?
maybe for her.
Okay.
So, first of all, the last meeting we had, great information, the packet of stuff that we got. Thank you, really appreciate it. The one thing I personally didn't find that beneficial was the part of the presentation on justifying how our stars are compared to the population of other nursing homes.
Okay.
Just my personal opinion is that's what a losing team does to justify their spot versus had that been this nursing home is 4 stars, this is what they do, and this is what we're going to do to get there.
Sure.
So I mean that's just my personal opinion.
No, I appreciate that, and I know you're not the only one who has that thought, and whether we are second on the list or last, I'm fairly competitive. Some folks know I like to be first, but I am also somewhat realistic sometimes. But the point is, even when we talk about the quality measures at Graysdale, they're compared to state and national averages, which is what it has to be. I get that, but the folks that we have at Graysdale are sicker.
Sure.
They have more mental health issues than privatized nursing homes, and so the sole intention of that, from my perspective, was to compare apples to apples. There is no excuse. We need to do better. We will do better. We have the right team now to do better. I'm not sure we're going to finish first. I'd love to, and we're going to do everything we can to do that. But that was the intention. I realized that was not necessarily felt or appreciated. I respect that.
I have a question.
Yes.
And I want to say, Mr. Werner, he shouldn't feel like I have no more questions. This is a concern I have, and I know I addressed this with our last president, Mr. Kraft. This is a time when council gets a chance to get into
Absolutely.
things. If something blows up big time, people say, well, where were you? It's like, well, I felt we were running out of time, and I didn't ask the question. Nobody cares about that. They don't want to hear that. I know at one time we'd have 2 Human Service Committee meetings a month. There was a time. Now, I'm not suggesting we need to do that, but I think it's very difficult. For example, on any given topic you brought up, I wrote some notes. You can spend easily half an hour on children and youth. You can spend easily 20 minutes on aging. And they say, well, you shouldn't have all the... That's what we do. I mean, for example, I could come to you specifically and say, I have a question, and call you. But if I hear Mr. Warner say something, or I hear Mr. Dietz say something, that might trigger something in my head. So this is a full group thing. And I just think we as a group have to think about the largest department in our county that affects the most people with the most employees, that no one on council should feel under any pressure not to ask a question because we're going to run out of time. And I just think it's something we need to discuss going forward. Because right now, Graysdale is a big deal. I read everything you gave me last time. It's quite a lot to read. And I think there's a lot of reasons for it that aren't somebody's fault. But that's a big deal right now. But I don't want that to overshadow the CYF discussion, where there's things going on, or the mental health discussion. And so I can see now, I mean, we're a minute before 6 o'clock.
Well, the good news is you've asked me a bunch of Graysdale questions.
Well,
Do the committee members feel that there needs to be more committee time? I have thought about moving this committee time so that we're not crunched up against council meeting.
May I comment?
Well, I wanted to ask the committee first. Do you have an opinion about that?
I just don't want to see us restrained, but I mean, I think that's a decision that a majority of the committee should make. I'm not saying we need to have 2. Maybe we should change the time, but I don't know.
Well, just to say, I think it worked out well, like the last time that we, so obviously there are certain circumstances at certain times that a specific amount of time needs to be dedicated towards it. So, we could have a, once a quarter, once a half, or something like that, a real breakdown on a certain department, in such case that it's warranted. I don't think we necessarily need to have 2 or more time to it, but.
I suspect that in a few months, the Graysdale information will be not as lengthy, maybe 3 to 6 months out. I think there's a lot now that we are here and learning and wanting to share with council. I'm not sure that'll always be the case, but that was just my. We obviously are here to serve you well, and we'll do what you need and answer as many questions as. Don't feel like you can't ask questions, please.
But I agree with Ron. I think that there's so much that you gave us tonight that we could spend more time. And I don't ever want what happened last time with you having to wait to happen again. So if we need to move the meeting to make it more productive and reasonable, then we can do that.
Sure.
Because it's the biggest part of the county budget. It deserves time and attention.
Well,
Agreed.
Should we then make it on a night that it's like on the Wednesday, or so it's not up against the county council night? So like, we had the capital projects meetings like that. If it happens to run for 4 hours that night, it's a long night, but doesn't have to be a cutoff.
I've actually thought about putting it on the first Thursday, but earlier, and starting it at 3:30. Starting it before Bill's meeting, because that way they're all here. It's, more access to employees. And then it would be an hour and a half designated before his meeting actually starts. So it would give us an extra half hour guaranteed. That's one thought I had, but I'm open to other suggestions as well.
If we could interrupt the process questioning, I had one that does relate to Graysdale. The county executive just made reference to the cost assessment and accounting.
Yes.
And I don't think we can understate that, because you weren't here when Graysdale was running $6 million deficits a year.
No, only the
So
stories,
what they did was significant.
Sure.
And I kind of sat here and held my tongue, while some of the bashing went on at the last meeting. But when Premier took over, Graysdale was running $6 million plus operating deficits. Now, the fiscal report that we got for Q4 indicated that Graysdale ran a $3.3 million operating surplus. So I think that is a big plus. And one of the things that we did is we implemented a stopgap that prevented that money from going back to the general fund. And now Graysdale is sitting on a $5.5 million fund balance.
Right.
So I guess, my question is, the objective of Graysdale is not to make a profit.
Sure.
I guess, is that surplus the result of inadequate staffing? or understaffing? That's my question.
Yeah, it absolutely is. That's how they did it. I mean, that was their man. Now, to be fair to Premier, that's how they were tasked. They were tasked to run the home so that the county would not need to make any county contribution, because we came off those years before the attempted sale of $6 million, some years $6 million county contribution to the county. So yeah, it is exactly how it was run. But to be fair to them, it's how they were supposed to. But it's why the morale got so bad.
There's no question that they dealt with cost over care. That was part of the problem. It was cost over care. We also had the IGT infusion, $2 million, 2.5.
Not to be overlooked.
Which helped put Graysdale in the black on the books, which we needed.
Right.
At the same time, though, and I don't want anyone to take offense to this. I worked with Dee Freeman. We were all there. A lot of you weren't. Okay. And they did a lot of legwork in the beginning to try to assess things that were wrong. And I don't want to take that away from them. I'm not saying that it was Premier necessarily. Just saying maybe some of the people that were in those positions didn't do a job that they should have. And I won't name names. But the fact is that from 2011 to 2013, we were doing well. And then from 2016 on, 2017, we were okay. We had 0 deficiencies. And then from 2017 into 18, with one of those directors, we seemed to go downhill. And that's not necessarily a reflection on the company. Because the company, I think, I reviewed everything that I thought was necessary. And I was sincere about that. They put a lot of time and money into, for example, risk management. We saved over $800,000 for risk management because they put somebody there to work with the workman's comp fee. So, yes, I do agree that Premier at the end, their directions were not, I called it a lie. I called them that dashboard was a joke. It still doesn't mean anything. If we can't give the care at Graysdale, we can't follow through with the dollars.
And to be fair to Premier, they managed the home the way the Stouffer administration wanted the home managed, which was they wanted to ignore it. And so, right, and then the Brown administration had a slightly different take on it. Don't let it cost. We know it needs to be county owned, but we don't want it to cost us anything. And that has its price. But Madam Chair, you probably want to hear from Jen and Dawn and not Sue and I.
I do. I wanted to also
I'll
just
sit down.
put out. No, I don't mind that. We're just talking. We're going to run till 6:20, and people have the right to ask their questions. It's just that they are also here to answer those questions. So I think we should invite them to the circle.
Well, they know more about it than I do.
They can answer them, but
I have a comment, and it's going to be quick, and I'm not on the committee.
you can.
But I know there was a lot of debate here, and I've been sitting here listening too. And the first thing is, doing nothing is also a choice. And that's not the choice that the administration did. They made the choice to make it right. And, and not only that, but, I've been sitting here through these meetings as well, and they've been chasing fires for a long time. So, Mr. Warner's point, to put all this together, I get it. You got to ask the questions, and, and I'm sure we're going to get some of that information here shortly. But, and as far as Premier, that was their job, though, to get the worker comp people in order. That's their job. That's what they were paid to do. So, they're supposed to do that. That's what they're hired to do. So, I'm sorry, but I have to commend the administration for doing what they do, and I think Human Services is doing more than above what they need to do, anyway, that's all.
Dawn, you could sit here because people may have questions of you as well.
So once the new dashboard gets out, I'll start.
Susan, did you have stuff you were passing to us as well? Was that it?
I didn't see that. Jeez.
Hey, come on.
I'm listening.
Attention, people?
Chairwoman wants you to pay attention.
Hold enough for presentation.
Okay, so I'm going to go over everything I have on this new dashboard. If there's anything else you would like to see, just let me know, and I will make sure that it's on the next one. So the first thing we go over is January's monthly census, and we averaged 665 residents. For that, we had 138 inquiries into Graysdale, and we did admit 34 people, and unfortunately we had 34 discharges. So that kept us at 665. You can see underneath the census numbers, you have the monthly PPD, and that's the hours of care per day, which is the 3.45. So that is above even our budget level of 3.2, and we are working on that. So then you have the cost per resident day. So that is taking the number of actual residents we had for the whole month of December, this is for, because we didn't get all the outstanding bills for January when we were doing this report. So you divide it into the total expenditures, and it's about $320 a day. Underneath there, you see how much in December, how much revenue we get. So our monthly Medicare rates, they go for all-inclusive average of about $518.34, and a monthly room and board average of about $414.30. That, again, is the Medicare numbers. Underneath there is what we get paid for other people that are living there. You have the Medicaid rate of $221.92, semi-private room of $340, private room of the $350, and then our short-term rehab is $550. Down we have the December numbers for our agency usage. Again, I didn't have January's numbers, and I didn't want to, I know in the past report you kept seeing duplicate numbers each month. I didn't want to put January's numbers in without having all of the numbers at my disposal. So you have the cost per nursing agencies. So in December we had a total of $200,508.01. So that was just for our RNs, LPNs, and CNAs for agencies, and then it breaks down into the hours. So then you go to the second page, and it talks about wounds a little more in depth. So it talks about the newly acquired. So in-house you have about 18, and then we had wounds upon admission were 10, acquired while out at the hospital were 4. So the total wound number for the month was 77, and healed, minus out the 19, expired or discharged, you minus out the 5. So our ending wounds for January were 53. Reportable infections, we had 119. 6 of them were present on admissions, and then 32 of them required us to report to the state.
What's categorized? What does that include or encompass?
That includes so urinary tract, respiratory, soft skin and soft tissue, and the GI infections. The incident reports were 332. So that's just different things that came up, whether it be falls, different things that happened at Graysdale. So there were 332. It could be elopements, resident-to-resident assaults. Then we have, I showed the falls for 172. So that number is high, which we have a falls committee that we're revamping all the policies, and we're looking at evidence-based programs to put in place. So we are attacking that very hard.
And I think I asked a question, I forget if it was last week or if I talked to Susan about this, but I know what the regulations in a regular hospital for falls are. It's 0 tolerance. Are the regulations different in a nursing home?
No.
Because there's more reason there's different reasons why people fall. So
right, it's still 0. No falls. And with the QMs, the quality measures, so if one person has 1 fall, they stay on the QMs, the quality measures, for 1 year to look at it. Yeah, so it's very hard once you've had that one. You have to wait a long period of time to get them off. And a fall could be anything. So if you're in a low-rise bed and that's a bed that goes all the way to the floor, and maybe somebody's sitting on the side of it and they just slip out, tied on a sheet or whatever, and that's a fall. You know, it could be anything. If they touch the ground, it's a fall. Oh, so, and that's another thing. So because we are in a restraint-free environment as much as we can, technically you have the right to fall. You have the right to get up. If you're in Assista 1, you know, you're not going to have somebody to assist you all the time. Or if you're walking with a walker and you fall, that's, in essence, you're right. You know, because you don't want people hovering over you all the time.
Okay.
You have the right to be as independent as possible.
So, with the right to fall and the zero tolerance for falls, what's the liability of that person falling if they invoke that? Like, I can fall whenever I want, you know?
It's very, very hard.
Excuse me, am I mistaken, or is it still, nursing homes have more regulations
Yes.
than hospitals when it comes to care?
We're
It used to be.
nuclear.
Yeah, I mean.
Yeah,
and
we are
some
one
of
of the
them
most
just go
heavily
crashing
regulated
into each other.
industries there is.
That's just insane.
Mm-hmm.
I have another question. So I was looking at this, and it said that, you know, the average daily census is 665, and the cost per resident per day is $320. So when you multiply that, you get $212,800 dollars and change. And it says here that your total nursing agency's cost, I'm thinking, is $200,508.
Well, and that 320 is just it's an estimate, because then you have to add into your Medicare rates, your private pays. So on the basis, if you just took everybody, the 20,000 days that somebody was there, and then just divided out at the expenses, that's where you get your $320.
Okay, because my question was then, is there a surplus in this month, or that surplus has gone to other things that are not on this form?
Well, we're hoping that January is going to be a little lower than what these costs were, because again, we had holidays in there, so there was a bigger expense in December.
Oh, okay, but okay, so I guess my question is that are you making any profit that you can reinvest in, or reinvest in the foundation?
Yes.
Okay.
So, and we are, and that's something that hopefully we'll be able to show what we're doing as things matriculate into fruition.
Okay.
So, yes,
yeah,
we are.
so you're not operating in the red. That's good.
No, we're looking at furniture. We're looking at sprucing it up. We just did, when Life Safety, which is an arm of the Department of Health, was in, they told us that we had to remove the paneling down from the riverboat room. And it was in a Cracker Barrel room. We had to take it down as well. That paneling's been up, and the residents adore it. It's beautiful. Has to come down. So
paneling, huh?
Yeah. So now we're reinvesting. So we're getting updated carpet. I work with the president and vice president of resident council. Help me pick a color. You know, what would be soothing for you to be in this room? And they looked at the carpet. So we're making the residents, you know, bringing them into a lot of decisions.
Very good.
It makes them happy.
Yes. Well, they have to live there.
That's what I said to them. I said, this is your home. You should have input into what goes on and what changes. So then we have the staffing. So these are some of the vacancies that we got from HR department. So they're according to FTEs. So you can see for CNAs, we have 71.6 FTEs. LPNs, RNs. It goes into dietary, laundry, and housekeeping. And this, again, is something that Dawn has been working on so that we really streamline where we put people and who we hire. When I was hired as an aide back in 2005, I went in part-time because I was going back to college. And I said, this is great. I would get 4 days on a blocked floor. So that means I would go to the same floor for 4 days, and then I'd have one center day, which means they can send me wherever. So I went in for my interview, and she said, well, I know that's what the position says, but I'm going to guarantee you're getting 9 days. Okay. So there was I wasn't going to get 5 days at all. Every week I was scheduled for or every 2 weeks, 9 days in that pay period. No ifs, ands, or buts. Couldn't take off, couldn't. So this is going back again to 2005. Dawn is redoing that if you come in and you only want a block day, you want to work your 4 days block part-time, that's what you get. How great is that? Because that's going to attract a lot of people who can't work a full-time. They only want to work part-time. So those are some things we're looking at. It's more attractive to a lot of people.
Does that affect the benefits that they're able to get if they only work part-time? And is that a motivation for having only 4-day work week?
They don't get, part-timers don't get benefits. AFSCME, the union that they're in, does give part-timers some benefits, but we don't pay benefits to part-timers.
Okay. But that's not a motivation for switching to part-time work?
Mm-mm.
Just checking. It wasn't ours. Oh, it wasn't yours. Okay. Very good.
We didn't consider that.
Okay.
So we did have one state visit. I believe that was January 4th. So when that occurred, it was unsubstantiated, but we were nervous, and we knew we had all our ducks in a row, but because it's still an open survey, and we're even open right now, so anytime they can come back, it could count towards our survey. But it was unsubstantiated. Everything worked out. We had all our documentation all ready for them. So you had mentioned some of the things that we do, that other nursing homes do that we should do. And I want to let you know that we have a lot of the things in place, we're just not using them. So you have Cedar Brook has an electronic health record system. They have point-click care. They have Relias in, and it's working. They have, their teams, their committees, their pain committee, which I'm reestablishing. The Falls Committee, we're reestablishing that we haven't had in a long time. So we're taking the different models that are out there, and we're making sure that we have everything that they have. For 4 years, we had to deal with an electronic health record system. It just did not work. And we have complained. We went to everybody. And thank God, Mr. McClure was the only one who heard us. So we're very happy with that.
Yeah, and I hope to not take offense to what I said before, with it. But I just really look forward to, that we're finding reasons to improve it and not justify,
And it's frustrating for us because we know we have the pieces and we have to get them rolled out. So, we're hoping Relias, we just got told that we're looking at an April 1st go live date. So we're very excited about that, and we're working very hard to make sure there's no hiccups in this.
Yeah, because I was thinking anyone else in council, but if you presented us and said, Cedar Brook is doing this, and if we allocated this funding to it, we could, use some stats to back it up how we could do it,
Well, absolutely, and that's why Dawn talks to a lot of the directors of nursings and other nursing homes. I talk to the administrators, so to find out better things. We belong to PACA, which is the county nursing homes group, and we're all talking to each other and finding out different things that works better,
Can I ask a question?
Absolutely.
I think you've pretty much gone through your...
Yes.
I have a question, if you don't mind. Is this going to be the new dashboard?
It is, but that's what I'm saying. It's the first time you're seeing it, so if there's anything you want tweaked, if you want color.
Well, no, I have a question because it came off of our last meeting, and it's going on what isn't on this dashboard that was on the old dashboard. For example, when I was looking at things that I was concerned about, the benchmark for pain long-term was 6. We were at 11.16.
Right.
Antipsychotic medication utilization benchmark 14.7. We were at 21.9. And pressure ulcers, facility acquired, 46.9, healed, 30.17, and my quick math came out to, so we have a 63% success rate. To me, I think those are important to know, at least to me.
Okay.
And I don't know how the rest of the committee feels, or even council. I think this is a nice report.
And we broke down the wounds on the second page, which was a little clearer. It goes over how many were in-house, how many were...
But I agree with what he's saying.
Right,
I wouldn't want to throw
percentages.
out some of the other data that we were getting. Like the case mix index is one thing, but the pain management stuff, the antipsychotic stuff, because I think it all leads together. Some of that stuff contributes to the falls.
That's why.
And I think it should be studied.
The antipsychotic, I'm because I think we've had this big discussion
Right.
about it. Everything in human service is expensive. Period. Just this. We do human services. A nursing home is hard. It's hard to run. It's hard to manage. It's a difficult place. And if we're going to do it, we have to do it as well as we can, knowing what we're up against. Graysdale, specifically in a public agency, is going to be in the press more. It's going to be out there more. You're getting hit with things other places can sort of handle behind the scenes. But this antipsychotic going forward, one of the reasons I want to keep an eye on that is because I believe our population is going to change more dramatically than private homes because of their refusal ability, and ours too. But we have traditionally, and I don't think that tradition has changed, have taken people who may have been turned down by other places, or who have, since the close of the state hospitals, frankly, a lot of people went on the street that shouldn't have been on the street. And we had nowhere for elderly to go who have severe problems other than nursing homes. And the nursing homes know that. They comb through that information from the hospitals. So lo and behold, I think our population in that regard is going to go like this.
Right.
And the very things you mentioned, restraints, not using restraints, I see concerns going forward, and that's why I'm asking for information.
Absolutely.
To help me. I just thought it was helpful, and that's all I have.
So at this point, it's 25 after. I think there were questions I had that we didn't even get to. I think one thing that would also be helpful, if Susan, if you have some stuff that you could also send via email, like a report prior, because you had a lot. And if that stuff could be written or sent maybe prior to the meeting, then that way, then people can read it and ask the questions rather than you having to you know, if you had a handout or something, that would help expedite time. Is there anything anybody wants Graysdale to have ready for next time that they want to hear about? I still wanted to hear more about the competencies. Susan and I also discussed the QAPI. I think that's something that deserves discussion because I think it's a solution-oriented program that should be highlighted. So, because I think if people hear what you are already doing behind the scenes that you're keeping, that might help. So,
absolutely.
Anything else?
Thank you.
Any parting shots? All right, I move to adjourn, and we'll take time.
Peace and love.
Jo, ještě